Muchas gracias, presidente. Ahora nuestros primeros ponentes de hoy son el doctor Stephen Wolf y la doctora Patricia Magoldrick. Sorry. El doctor Wolf es el jefe de Neurología Infantil del Hospital Mount Sinai y él junto a su equipo están especializados en epilepsia, trastornos del desarrollo y autismo. Durante los próximos minutos nos hablarán de la epilepsia, las encefalopatías epilépticas y el síndrome de Landau-Kleffner. Sobre todo incidirán también en los tratamientos de avance que se están utilizando en estas patologías. Muchas gracias a los dos. Thank you.
That's the extent of my Spanish, so I'll do the rest of it in English. So we run a big epilepsy center in New York City. We have a lot of children with epilepsy, but we also have a lot of experts here today. So we have two very distinguished professors of medicine who specialize in epilepsy and in epilepsy surgery. Oh, it would be helpful if I turned on the speaker, sorry. So we're going to talk a little bit, an overview of epilepsy, then we're going to talk more specifically about Landau-Kleffner syndrome, and then about some of the new treatment options that are available in the United States and are probably not yet available here, but will be soon. So we weren't sure who our audience was going to be, but I understand that a lot of you are parents and family members and educators. So we're going to talk a little bit to start with about seizures. Do you want to put the next slide?
Sure.
Okay, so a seizure is, we often describe it as sort of fireworks going off in your head. It's a sudden discharge of electricity in the brain. The neurons are firing very rapidly, and they cause a change either in motor activity or in level of consciousness or behavior or a sensation. And it's this abnormal electrical discharge of the neurons. About 300,000 persons per year have one seizure, have their first seizure, and about 10% of people over their lifetime will have a seizure. So how do we decide that it's epilepsy and not just a seizure? So epilepsy is made, the diagnosis is made when you have two or more unprovoked seizures. So that means that you have a seizure that wasn't caused by staying up all night or drinking excessive amounts of alcohol or being in an accident, some sort of trauma. Or you can have one seizure and have a very abnormal EEG or electroencephalogram, and then you can make the you have one seizure and your EEG is so abnormal that we really think that there's a big chance you're going to have another seizure, then you make that diagnosis of epilepsy. And what testing do we do? It's the same testing that you people do here. We do an EEG, which is an electroencephalogram, and if you look at the picture of the brain, so that's, we put wires on the head to look at the electricity in the brain. We try to do overnight EEGs, 24-hour EEGs, so that we can see what the electrical abnormalities are during the night and during the day. We do an MRI, so that we can look at the structure of the brain. We do neuropsychological testing, especially important in children who may have associated problems with learning or learning disabilities. And we're doing more and more genetic testing at this point, more so than we had done 5 years ago. So if you look at these pictures, these are our epilepsy units. So those are one of the children in our epilepsy unit, and then that's the control room that has all the computers all over the walls so that we can look at all the children who are inpatient.
So for those who don't understand EEG and they look like a bunch of squiggly little lines, basically what we're doing is measuring the electrical potential difference from one spot to another and subtracting it. And we're looking for these little I'm sorry. Basically on the EEG, we're looking for the abnormal electrical activity in the brain, and we're measuring the electrical potential difference from one spot to another spot. And this was designed or invented back in the 1929, and we have evolved a little bit over time. And basically what we're looking for is what's called a spike or a pica on the brain, and a special type of spike and pica that we're looking for, a special pattern that helps us to understand what type of epilepsy and also where the epilepsy comes from in the brain. This is what an EEG looks like, and basically you're looking at 4 or 5 seconds of a brain wave over time, and looking at the different areas of the brain. On the top you can see the odd numbers are the left side of the brain and the even numbers are the right side of the brain. And this is a nice normal brain. When you're looking at EEG, it's like looking at music. Sometimes if you don't know the music, it looks very complicated, but we're looking at all these different wave patterns that are mixed together. And you can see an example on the top of normal looking brain waves of different speeds. So we're looking at the speed of the brain, and then on the bottom you can see an example of the spikes or the picas that are abnormal. So, but we're looking this all together in a brain over time as we're trying to understand the child and looking for the patterns that could tell us a story about the child and help us to make a diagnosis. There are many causes of seizures. Seizures, we like to say, are a symptom. So an example of a symptom that you know very well is a runny nose. And we know that a runny nose can be caused by infection, allergies, something stuck up the nose. And your job as a provider is to find out what's the cause of that symptom. And seizures are a symptom. So we need to look deep to try to find the reason of why they cause, what causes the seizures. We know that there are congenital malformations, which are the brain wasn't developed properly. There are neoplastic or cancer issues that can cause it. Perinatal insults are when the babies are born, that there's some lack of oxygen or some event happens when the baby is born. Of course, genetic, which is what we're talking a lot about today. Infection can cause a problem. We know many infections. Patty and I saw a number of children over the past few days, and we've heard stories about infections that have caused seizures. Some trauma, and of course vascular has to do with abnormal blood supply. All these things can cause the symptoms of seizures and cause the children to develop the syndrome of epilepsy. When we look at the pie, we see that over time that many things have changed. We used to say we didn't know many times. 3/4 of the time, 75% of the time, we did not know why a child had epilepsy. But now, over time, we see that genetics has really helped explain why so many children are having seizures. And today, Dr. Pinto and a bunch of other professors who are joining us today will be discussing some of the genetics that is involved with causing the seizures that we see today and explaining to us why this is happening. And there are many different reasons. It's not very simple, as you'll hear today. One of the things that we're doing more in the United States, where we used to focus on EEG and MRI, now finally genetics is making a difference in how we treat the children, how we guess and prognosticate what the future is. And this is an example of some of the testing that we do commonly in the United States and here as well. The chromosomal microarray is a very simple test that looks for big chunks of deletions and things that are missing in the DNA, but it doesn't get us down very deep. It doesn't get us down to where the proteins that cause the problems, the mutations that cause the problems in the proteins that then cause the problem in the children, it doesn't get us down deep enough. So in America they're doing, and here they're doing more genetic panels that are cheaper with the help of something called next generation sequencing, which is a much lower cost ability and faster ability for us to look at DNA. Gene panels look at what's called exomes. So they only focus on somewhere around the 22,000 genes that make proteins that are involved with different processes in your body. Unlike whole genome, which looks at your whole millions of genes, that's much bigger. So right now we are focusing on just panels which only look at somewhere between 50 and maybe 500 different genes that are involved with epilepsy. And we know that some of the doctors that we met with on Monday are already ordering these tests here to help decide what type of disorder the children have and explain why they're having the epilepsy. This is an efficient way of making a diagnosis and sometimes gives us a yield of only up to about 50% in most of the children. So that means that there are many children that the genetics do not tell us the story and only help us a little bit. Oh, so today we're just going to talk about a specific type of childhood epilepsy, and there are many different types of epilepsy. There are some that we outgrow as we hit teenage years, and there are some that we do not outgrow. So most of the time we are lucky enough, the professors and us, to see children who outgrow their epilepsy and the parents relax. But many of us know that there are some syndromes and some genetic disorders that cause epilepsy that do not go away and affect how we learn and affect how we grow up and how we develop. And we are learning that the earlier we detect these type of seizures, the better we can help these children learn, and it helps their whole future and their development. So it's one of these disorders that we want to focus on, which are the childhood epileptic encephalopathies. And one of the professors today will be talking about the genetics of childhood epileptic encephalopathies. But today we want to focus on one particular one, Landau-Kleffner syndrome. But you have to understand that saying you have a epileptic encephalopathy is a broad term. It's like saying you own a car, and today we're going to talk about one little sports car. So it's one little segment of the family of epileptic encephalopathies. So Landau-Kleffner is one little portion over here, as where there are many different examples of epileptic encephalopathies. But what's important about these two types, epileptic encephalopathy CWSW, which is continuous slow spike and wave in sleep, and Landau-Kleffner, is that these children lose skills. So they develop normally, they have normal speech, they're developing speech, and suddenly they lose an ability. They lose the ability to talk and to discuss, and even to process and to lay memory. And so this is very important. Now, sometimes in the Landau-Kleffner syndrome, Patty will discuss that we don't always see seizures and we lose language. Go from there.
Well, no, you're going to talk about the spikes next. Let's talk about spiking.
And the reason we are interested in children who lose language, so these children have no seizures, no convulsions, but they suddenly lose language. And what we see on their EEG are the spikes, the picos. And what we are interested, our research in America, is how the spikes interfere with learning and cognition and laying memory. So we focus on spike density, how often the spikes happen in 1 second overnight. And you know, as you sleep, your brain changes over the nighttime. And when you go to sleep, sometimes we see many, many spikes, and sometimes we don't. So my point that I want to make is spikes are not good, but the most important thing is when you're doing an EEG to look at sleep. Because where a lot of tests are only done during the day for 1 hour, if you don't look at natural deep sleep, you might miss the spikes that are causing the language to disappear. And you might miss an important secret of what's going on in this child's brain. So we've been focusing on where the spikes come in the brain, as well as how frequent they're happening in the brain, and how that is interfering with how language develops in the brain, and why these children lose the ability to talk.
All right, so specifically, there's a continuum of epileptic encephalopathies. They start with ones that we've always felt are not that severe, and they're the one that is usually identified as something called benign Rolandic epilepsy, or BECS. And that's usually thought to be benign, and the children outgrow it. But then further along that continuum is Landau-Kleffner syndrome, and then CSWS that Steve just talked about. So what happens in Landau-Kleffner syndrome, it's partly reversible. So the children lose language, but may be able to gain some of the language back, and I'll talk about that in a minute. It usually starts before the age of 6, not at the same time as autism is commonly diagnosed. And what happens is they stop talking, so their talking gets worse. And then they have some cognitive and behavioral issues, usually related to not being able to communicate, because you can imagine how frustrating it must be not to be able to get the words out and not to be able to talk and make your needs known. About 3/4 of these children who have Landau-Kleffner syndrome will have clinical seizures. So clinical seizures are when you actually have a seizure, not just the abnormality on the EEG. About 1/3 of them have prolonged seizures called status epilepticus that are hard to stop. Often the seizures are in sleep, which those of you who are parents, that's very scary, because if you're not sleeping with your child, you wonder what's going on when you're not in the room with them, lying next to them, and you're wondering if you're missing seizures. The EEG is abnormal over the language center, and often more abnormal, as Steve said, in sleep. So it's not autism. A lot of these children are misdiagnosed as having autism, and if they're not going to an epilepsy center or to someone who really specializes in epilepsy, they may not be diagnosed. They may be told, oh, your child is autistic, without doing any underlying testing. So they start losing the ability to speak, and then lose the ability to understand. It's rare. This is not a common disorder, and it was first identified back in 1957 when Landau and Kleffner, that's why it's called Landau-Kleffner, because the two doctors who identified it were named Dr. Landau and Dr. Kleffner. A lot of things in neurology are named after whoever discovered it. So in 1957, they identified 5 children who had stopped talking, so acquired aphasia. These were not children who had never talked. They were children who had talked and stopped talking. And they had, at the same time, seizures. So what they noticed was that as the seizure control got better, the language got better. So usually these children lose language between the ages of 3 and 8. And then there are abnormalities on the EEG, and then these associated behavioral issues, which are understood because if you can't talk, it's hard you're trying to misbehave so that people will understand. So it occurs usually in a child who is developing typically, and then all of a sudden they lose language, or they start losing language. However, there is a subgroup of people that we feel may have had a speech delay or some language issues to start with, and then they get worse. And there are several neurological conditions that present in childhood that may start out with a little bit of a speech delay, and then it gets worse and worse. So the thing to remember is that speech delays usually don't get worse. They're static. They get better with therapy. They don't get worse over time. So if you're seeing a child that had some speech delay and now it's worsening, that's very important to send them to a child neurologist for testing. All of the children with Landau-Kleffner syndrome, or LKS, will have an abnormal EEG. It usually is abnormal on both sides of the brain, but it can be just on one side.
and again, concentrated in the areas that are known to be important for language, and they're usually increased spiking in sleep. Sometimes it can be mistaken for deafness because they can't hear, they can't speak, so of course you would think that they can't hear. It can be mistaken for deafness, for autism, for neuropsychiatric disorders, things like attention deficit disorder, oppositional defiant disorder. I don't know if they're the same names here. They start having fine motor issues, so they have trouble writing, coloring, drawing, and they begin with not understanding spoken language. So gradually you'll see this increase in misarticulation. So they're not pronouncing things correctly, they're not understanding sounds. The first thing that you'll see is that they're not understanding what they're hearing. So it may be something as simple as the siren, the fire siren. They don't remember what that means, which is a big problem with safety for these children. It can be gradual, so it just gradually gets worse, or it can be incremental, so it gets worse and then it sort of plateaus and then it gets worse again, plateaus, gets worse again. So just when you think things are getting better, it gets bad again. But again, the first problem is with the interpretation of the sounds. The EEG, which we can talk about.
The area that we look at the most is focusing on the left side where your speech center is. And most frequently in these children, you see the spikes
That's on the right.
happening on the side of where the speech center is. Sometimes we see it on the opposite side, you know. Oh, sorry. So most of the time we see the spikes on the left side of the brain where the speech center is, but sometimes you can even see it on the opposite side and we see the spikes happening here. But as you see what normal looks like, you don't normally have spikes. So this is important to look for in sleep.
So the other thing about the EEG is that if any of you have ever had an EEG or had children who had an EEG, we'll flash lights during it and we'll make them hyperventilate, breathe really fast. The spikes in Landau-Kleffner don't get worse with either hyperventilation or with the photic stimulation. So that's important to remember. So why does it happen? That's what we keep trying to figure out. So there have been several articles recently about the genetic basis for Landau-Kleffner syndrome, and the only thing that's turned up yet is the GRIN2, GRIN2A mutation. There's a couple of other genetic abnormalities. There's 2 or 3 others that are identified, and one of our partners, Dr. Pinto, is going to talk more about our whole exome sequencing later on and what we found thus far in a subset of children with Landau-Kleffner.
The most important thing to understand about what we're learning about the genetics is that you could have a gene, say the GRIN2A, and you might have a very severe epilepsy or very mild epilepsy. So we talk about phenotypes, how the child looks with a certain gene disorder, and right now it's very confusing because the same mutation can cause very different story, and we don't understand why that happens. And so you'll hear from a number of geneticists today, in Spanish, better than in English, why there is that difference and what we're learning about that.
Now, the other thing that's interesting is that there was some thought as to that there was something pathologically abnormal about the brain, and there was a series of children who had surgery for Landau-Kleffner, and when they looked back at the pathology, there really wasn't anything. They had partial temporal lobectomy, so part of the temporal lobe was removed. And the only findings on the pathology were some subpial gliosis and occasional fibrous astrocytes, which were not pathological. The other thing that we've shown is one of our researchers in the States, Harry Shigani, has done a lot of PET scans on children with Landau-Kleffner. And what the PET scan looks at is the metabolism of the brain. And what he found is that there's abnormal metabolism in the middle temporal gyrus, which goes along with the abnormalities on the EEG.
So the problem when we're looking at the brain is we can only look at the electricity. We can look at the structure by looking at the MRI, and now we're looking at the genetics, but it still doesn't explain the story of how the neurons all communicate with each other. Where is the problem? So it must be somewhere between the structure, the electricity, and the genetics of how they all communicate and talk, that part of the story we don't understand yet.
Now, how do we treat it? So this is the big problem, is that you have to treat very aggressively, and what we try to do is to normalize the EEG. And then we think that once we've controlled the seizures and the EEG becomes normal, the other things will fall into place. The language, the behavior will get better. So what they found going back was that people who were treated with phenobarbital had worsened the behavior and didn't improve the language. There was some also tegretol, carbamazepine, and phenytoin caused more activity in sleep, which is interesting because those were medications that historically were used for seizures that started from one area of the brain. So what has evolved over time is the use of high-dose benzodiazepam, so that's Valium, diazepam, clobazam, we use a little bit of Klonopin, clonazepam seems to work. There are lots of other anti-epileptic medications that we use that we'll talk about a little bit later. High-dose steroids, IVIG, which is intravenous gabaglomulin. In the United States, we have just legalized medical marijuana, which Steve will talk about later. So we haven't tried that in anyone yet, but that's another possibility. We've tried diet, the ketogenic diet. People have tried surgery in the past, mostly sort of a raking of the area, which I'll show you, and then adjunctive therapies. So the biggest, they did a survey on people treating CSWS, which is on the continuum of LQS, and most people thought that steroids and surgery were the best outcomes. So should we talk about this? Let's wait.
We'll come back to this.
Yeah. Well, so the surgery options, typically in the past, what was done most frequently was multiple subpial transections. You can talk.
So we have a professor who will be speaking about surgery today, so we just want to give you a tease, a little warm-up for your talk. But the two, instead of taking out big pieces of brain, in America they've done these things called subpial transections, where they just sort of make small cuts in the brain to decrease the interconnections horizontally, to decrease the spread of the spikes. This doesn't work very well. There's been some data that has been published on this with some improvement in some children, but overall not so good. The big move in America is to try to not take pieces of brain out, and this little device is called a responsive neurostimulator. And basically what it does is it detects when a seizure starts, and then it zaps it with electricity to stop it from happening. So it's basically like fire fighting with fire. And basically we do what you do with a stereo EEG on the left to localize where the seizures are coming from. Once you know where the seizures come from, we put this device in the brain, which then is programmed to detect the spikes. So you teach it like a computer to detect when there's a spike, and then you teach it to zap it. And every day the family uploads the computer into the sky, into the cloud, and then we look at it, and then they come in once a month and we program the device to teach it. So basically it's a very expensive EEG machine in the head that you can program and provide stimulation. So it's another option.
Okay, so we're going to go back and talk about why Landau-Kleffner syndrome and the epileptic encephalopathies are different than autism. But there is a high incidence of epilepsy in children and people with autism in general. But the age is different. So Landau-Kleffner, the regression happens later. About a third of the parents of children with autism report that they lose language between 1.5 years and 2 years old. 95% of them before the age of 3, so sometime between 1.5 years and 3 years old. But only 13% of the children who were diagnosed with Landau-Kleffner had regression at that age. So there were 2 pivotal studies discussing that. The other thing is that with Landau-Kleffner, it seems to be related really just to the loss of language, whereas in autism, they're losing social connectedness and eye contact.
It's so important that we recognize early the difference between autism and we don't miss epilepsy, because many children we've seen that already carry the diagnosis of autism, the doctors stop looking for reasons of why they have the autism. They stop looking for reasons why they lost the language, and that's why we are trying to teach people to differentiate between what's plain autism and then how far you should investigate before you just say, oh, we don't understand yet, it's not epilepsy. So I think that's important.
So the big thing to remember in LKS is these children still want to be social. They enter social situations. You need to do the EEG during sleep to look at it, and then there's the EEG abnormalities. So we'll often do prolonged EEGs in children with autism if they've had a regression, and oftentimes they're normal. So we try to do that typically for everybody. So the language therapy, when you start, what they really, really need is language therapy. So it's not just speech therapy. It's not just for articulation and getting the words out. They need language to communicate and to learn. We'll have them use sign language. So we'll also use systems where they can point to things on an iPad and it will produce this sort of mechanical speech. But sign language is easy because you don't need anything with you. You just need your hands, and you can do sign language that way. So it's portable. The other thing is that there used to be, in the United States, people would feel that if you taught children sign language, they would never speak, and that's not true. They can still speak after learning sign language. The slides are a little out of order, so bear with me. They can also, the other thing that people used to be told in the United States was that if children had been speaking two languages, if they were taught one language at home and then learned English at school, they would be told, the parents would be told to stop speaking the first language to the child. And then there would be a big delay in getting a speech therapist who could actually speak both languages to the child, but that's not true. So you need to continue speaking the two languages to the child, and the therapy should be provided in both languages, which I guess is not as much of an issue here, but we have lots of families whose first language is something other than English, usually, most often Spanish. And they just have such a delay getting speech therapists, and then the parents and the family can't communicate with the child if the child is only being taught in English. Now, in the United States, what we have in the schools is we have a continuum of services that are available. So we have certain services that are used for children who have any medical diagnosis. So it's called 504 accommodations, and that's a federal program that anyone who has any kind of medical diagnosis, diabetes, they broke their leg, cerebral palsy, epilepsy, they can get help at school whether or not they have a learning disability. Then there is another level that's called an IEP, so an individualized educational plan, and that's for people who have a learning disability and may or may not have a medical problem. When they are under the age of 3, they have something that's called early intervention, and each state has a little bit different program, but every state has to provide this. And someone comes to the home, and then when they're old enough to go to a preschool, the services are provided in the preschool. When they turn 3, it's called the Committee on Preschool Special Education, and that is paid for both by the federal, the state, and the local government. The early intervention is paid for by the county or state government. When they turn 5, and they would be starting regular school, kindergarten in our case, then it's called the Committee on Special Ed that provides the services. They're tested every 3 years. They get a written report. And they get whatever therapies are deemed necessary. They may be in a regular class with just having therapy. They may be in a class with 2 teachers. They may be in a small class. They can go to a special school. So there's a whole continuum of different services. They may go to a residential school. But they get therapies, and they get written reports every 3 years, and they get neuropsychological testing. So what we think is most important is an intensive language program, simplifying language, and alternative means of communication, which we talked about a little bit with some of the parents with iPads and PECS, picture communication systems. We need to manage the environment so that the environment is quiet for them. There's not a lot of background noise because these kids have difficulty differentiating. So when I talked about the fire alarms, they also, the chair moving in the classroom, the people walking in and out of the classroom are very disruptive for them. We also try to facilitate socialization, so we have social programs for them so that they're with typically developing kids and they learn how to socialize. The big thing in the school is that their performance varies throughout the day, so that the teachers need to be aware if they're seeing that they're not working as well and get back to whoever is managing medications, getting back to the parents so that they can have more testing done and see if the EEG is worsening. The prognosis with Landau-Kleffner, it's dependent on the length of time of the impairment. So if they lose language later, the outcome is better. So about half of them make a reasonable recovery. About a quarter have some partial recovery of language. And then another quarter have very significant difficulties going forward. They still have trouble with language. But even those who have a good outcome, so their language assessment is within normal limits, they still have trouble with short-term memory. And that's one of the biggest things that the teachers need to be aware of, is that it's hard for them to hold something in their head and remember to do it. So they have to, be careful about asking them to remember too much at a time. Those who have a very poor outcome may never have spoken language, but they can use other means of communication. So what we're feeling is most important is that anyone who has language regression gets the EEG and gets an overnight EEG so that we can see what's going on, and periodic assessment. So we don't do an EEG once. We keep doing it throughout the process, especially if they're having more trouble at school. We want to be able to reach out and educate everybody, even in the United States. We're from a big epilepsy center. We go to all these meetings, but there are plenty of people who are out in the country and don't have child neurologists available easily that are the people taking care of these children, and then they need to be educated so that they know when to refer and to get more help for these children. We want to see more genetic testing, more education for the schools, and more support for the families. Now, some of the newer things that we're seeing, which are new, this is epilepsy in general and not necessarily for Landau-Kleffner.
So one of the new things that we're doing in the United States is using cannabinoids to treat epilepsy. In the UK, this product comes from the UK and has not passed the EU board yet for being used in the European Union. You hear a lot about marijuana going on, but let me just sort of clarify what we're exactly talking about, because cannabidiol is not really marijuana, it's a component of marijuana. In our own bodies, we have endocannabinoids. This is what we endogenously make in our body that when we're working out or excited or feeling good, it makes us feel good. So this is what's naturally occurring in us. There are synthetic cannabinoids that are made by pharmaceutical companies that mimic this, but they're not natural. And then in plants, in cannabis sativa, which is your marijuana, there are components of cannabidiol as well as THC, which is what everybody thinks of marijuana as having. THC is the psychoactive component. So the two most important parts of the phytocannabinoids, what comes out of the plant, is the THC and the CBD, cannabidiol. But what we know is that THC makes us high, makes us euphoric, and it interacts with something called a CB1 receptor in the brain. So that's the part that causes the high. But what's interesting is cannabidiol does not interact with that at all. And so if you purify the drug and just get the cannabidiol, it does not have the euphoric component. But what we found in our studies with this drug called Epidiolex, which is made by GW Pharmaceutical, is that there was an improvement in epilepsy control in patients with very severe types of epilepsy. Now, this is not for the patients with Landau-Kleffner, but for the patients in that family of the epileptic encephalopathies that we've discussed before. So we were able to take children who were having 20 seizures a day and get them down to about 5 seizures a day. So there is an improvement. It's not perfect, but there's an improvement. So this is something new that's coming around that you'll probably be hearing about in the studies happening in the European Union over the next year. Our esteemed professor will be talking about epilepsy surgery and efficacy and control, and this is an example of someone who had a piece of their brain taken out inside their temporal lobe, deep inside their brain.
But what we're saying about epilepsy and surgery is that people are afraid of epilepsy surgery. This is not for the Landau-Kleffner population, but epilepsy in general, so that we need to lessen the stigma associated and the worry associated with having surgery and move people along who are failing medication so that they can get this as a treatment option.
There is certainly a cultural bias. Many families think the brain is a precious place and that surgery can't be done. And our surgeon will explain that it can be done extremely well and extremely safely. So it's important as us as advocates to the family before they meet the neurosurgeon to let them know that brain surgery is safe, it is effective, because us as the primary conduit, the primary person before they meet the neurosurgeon has to provide that confidence to the family that this is an option and we should consider this option. So just to sort of finish up, what we are looking at is that when someone's seizures are very difficult to control, we need to step back and to look and see if they are a good surgery candidate. Is this an area of the brain that's safe to resect and to remove? And if not, could we do with this little computer device what is called neuromodulation? Can we control the brain with a combination of medicine and a combination of electricity? And if not, there are 2 methods of neuromodulation, one being the vagal nerve stimulator and one being the RNS. And we'll talk more about that more. Okay. So basically, what we're just trying to say is that there are new options to epilepsy, that genetic testing is extremely important in evaluating children to help us guide and give guidance on what possible treatments to do in the future, and really to basically never give up. We met a lot of amazing mothers, Pilar being one of them, who said, this is not good enough for my child. What other options do we have? What kind of medicines can we do? How do we test a little further? What is next for my child? And we credit the mothers and the fathers and the families for keep pushing us doctors and providers to finding out what's the next reason and pushing the scientists to come up for the answers of why this is happening to our children.
And in addition, to treat the whole child and also take into account the needs of the family, the socialization needs, and the school needs are very, very important, because we can control the seizures. Usually we keep trying different medications, but what's really important is the therapy, the school, the family system.
You have to think of seizures like a trauma, and it's a trauma to the brain. And so, after a trauma, you need to do rehab and therapy, and school is that way of giving the rehab to the brain. Thank you.
Thank you all. Thank you, Pilar, for inviting us.